Good morning, everyone. Bob Ravenscroft, Vice President here at Bryan Health for today's briefing. Before we get to the statistics, just like to introduce our guest today. It's Dr. John Steuter, who is a cardiologist with Bryan Health. Dr. Steuter was raised way out in western Nebraska between Ainsworth and Valentine, went to the University of Nebraska, Medical Center and completed both his residency and fellowship there. He's certified by the American Board of Internal Medicine and holds additional certification in cardiovascular disease, and also has a FACC designation through the American College of Cardiology, and is very busy around here. He serves as the Chief Medical Officer for Bryan Health and is on the Medical Executive Board at Bryan Medical Center. Also, if that's not enough, he's the Director of the Bryan Health Improvement Program and the Director of the Non-Invasive Cardiology and the Bryan Health Structural Heart Co-Director. Very active in research, so we're thrilled to have him here. And he also works with lots of athletes, and just as he goes through some things today, I know a question that would come up is, have we treated athletes that are recovering from COVID? And the short answer is yes. Some have been younger, some of them have been middle-aged and so forth. So with high school sports starting back up, I think it'll be of great interest to all of you of what Dr. Steuter has to say. Okay, real quickly with our stats. At midnight last night, we had 445 patients in-house. We have now administered 16,380 COVID tests. Our positives now tally 1,966, and we have 204 pending results. The pending results is staying at a more comfortable level. The reference lab in Kansas City continues to have a really good turnaround time. We're holding steady in that, about 2.5 days from the time of taking tests to receiving results back. Of course, there might be a few outliers, but the average is looking very good. Number of positives in the hospital are 5, and they are all from Lancaster County. We have one additional patient that is also from Lancaster County that is in-house and pending the results. That was as of about 8 o'clock this morning. So all 6 of them are Lancaster County residents. 4 of them are in general care, 1 of them in progressive care. Thankfully, none of them are in the emergency department. I know there's been some questions about supplies. Cepheid is at the critical level. We do expect to have our additional supply arriving today. The Aries test, cautious, but we're in pretty good shape. And then for the stuff that goes to the reference lab, still in very good shape. With that, I'm going to turn it over to Dr. Steuter.
All right, good morning, everyone, and thank you, Bob, for that introduction. I want to take a few moments today and just discuss the topic of returning to play in our athletes, and specifically athletes that have been maybe affected by COVID-19. Over the last 5 months, we've seen COVID-19 affect every area of the sports world, from professional to college to high school to recreational sports and even personal fitness. Now, in the last 4 weeks or so, we've seen sporting organizations be able to open back up, gyms open back up, and as Bob mentioned, this fall sports seasons are right around the corner. And so, one thing that's probably important for us to think about is, are there any special consideration that these individuals who maybe have suffered from COVID-19 need to be aware of, or that their coaches or their teams need to be aware of to keep them safe as they're returning to play? So, as a background, we know hospitalized patients with COVID-19 infection, up to 1/3 of those patients may have some form of cardiac manifestations from the virus. These manifestations could be simple manifestations such as heart rhythms, heart failure, heart attacks, or a process called viral myocarditis. Viral myocarditis, in simple terms, is an inflammation of the heart muscle caused by the virus. This virus can cause scarring in that heart muscle, and down the road predispose those patients to having irregular heart rhythm, some of which could be fatal. So, at the same time, we know that sudden cardiac death in all individuals, about 10 to 20% of those cases yearly are from viral myocarditis cases. So obviously you can see kind of that crossover and reason for possible concern. With this in mind, the American College of Cardiology, along with sports physician experts and infectious disease experts, have put together some algorithms and some guidelines for us to consider as these patients are returning to play. So at this time, we'll just take a few minutes and step through this algorithm. As we mentioned, a large portion of those patients who are hospitalized may have some form of cardiac manifestations. Those are that moderate to severe degree of illness patients. Those patients, while they're hospitalized, likely are going to have some type of cardiac evaluation or testing already. This may be things like EKGs, blood tests, or ultrasounds to look at their heart to make sure that things are safe, or if they're not, things that need to be done to help take care of them. If these patients have any abnormalities in these tests, once they're recovered from their illness, discharged home, and they go to return to sporting activities or physical fitness, the recommendations are that these patients be considered for consultation with their primary care provider, sports or team physicians, and if abnormalities in any of that testing, have that followed up on to ensure that it's resolved, or if it's not resolved, next steps to make sure that they're being safe and taken care of. Probably the biggest part of this algorithm we should pay attention to is kind of the middle part of it, which is the low severity of illness patients or the asymptomatic patients. Obviously, a lot of our young athletes might do better with this illness and not have to be hospitalized, but still they're at probably some risk of developing consequences from the virus. So if they're low severity of illness patients, once they've gone through the appropriate recovery time, they should be considered for further testing, including that blood test to look for any damage to the heart muscle, EKGs or heart tracings or ultrasounds to look for any abnormalities in the strength of their heart. If this testing is normal and they're symptom-free, they should be safe to return to regular physical activities. If any of that testing is abnormal, then the next step would be consultation and referral on to appropriate levels of care. The other group of patients that would likely be fairly high for our young athletes is the asymptomatic patients. So these are patients that maybe were tested because of contacts with other team members or in bigger organizations, college, professional athletes. Some of these teams are doing routine testing on their patients to look for any evidence of just that disease throughout the team. Those patients, as long as they continue to do well, again, they're asymptomatic, they have their appropriate time away from the team to clear their virus and to not be contagious to their fellow athletes, then it's felt that they can start to participate in sports again at increasing levels of intensity as long as they're not having symptoms. Along that pathway, if they develop any symptoms, and those symptoms, are chest pain, shortness of breath, passing out with activities, then obviously that would prompt them to seek further levels of care. So this algorithm, isn't hard set. It's designed to give some guidance, for healthcare providers as these patients are returning to play. So. But hopefully a helpful document for us to use going forward. A couple other closing comments. While we understand that up to a third of patients hospitalized with COVID-19 have some form of cardiac manifestations, it's not exactly known what portion of those patients who are asymptomatic or low risk who aren't hospitalized, how many of those may have cardiac manifestations. We all expect and hope that prevalence is quite lower, thus decreasing those patients or athletes' risk, but something we'll learn more about over time and likely, obviously, will shape those recommendations going forward. And lastly, obviously, physical activity, exercise, sporting events all have numerous health events for all of us, young and old, both mental and physical benefits. As cardiologists, we strongly promote and encourage our patients and all patients and athletes to be active in sports, to be physically active, doing personal fitness. We hope this information, this algorithm just helps to provide all of us as healthcare providers, coaches, parents of these athletes to be aware of possible issues that may arise in these individuals as they return to play. We talked about possible risk from a cardiac standpoint for our young and old patients. One thing that has been seen in the pediatric population, obviously still somewhat cardiac related, is the kind of increased inflammatory response, almost kind of like a Kawasaki-like disease. Kawasaki's disease is a kind of just increased inflammation that young individuals get. Some of this is cardiac manifestations, but kind of a total just revved up immune system. So that would be one other kind of area or organ system to think about just from a generalized immune system. Obviously, our pulmonologists are aware of the scarring, that can potentially happen in the lungs in these patients long term. So that would be the other kind of main organ system of focus that we need to be aware of and follow for these patients who have recovered and going home, and just in the future of their care to keep a close eye on their lung status. Now, if you look at the average age of diagnosis for the COVID-19 patient in the United States over the last couple of weeks, everybody's probably seen those statistics that talk about it being 15 years younger from where it was when we started kind of the pandemic in March and April. So I do think that is a big driver of that, is the patients are just younger. They're having, low kind of severity illness that doesn't require hospitalization, or asymptomatic patients that are detected by screening programs. And so I do think that is playing into why you're just not seeing the hospital numbers, but still the total number of cases increase. There does appear to be an age variance. When you look at viral myocarditis just in general, we've known that individuals actually 15 or younger are less risk for sure from developing that just in all viruses. When you get into that kind of mid-teens, 20s, and 30s, that seems to be, from an athlete standpoint, probably a little bit higher risk of just all viral myocarditis cases. So there is some age variation there. As well, a lot of what we are seeing is, patients who maybe are in that kind of middle part of their life, 40s, 50s, it all depends on your perspective of age. But those patients who maybe have some other mild underlying cardiac risk factors, some high blood pressure, who maybe contract the virus, and are those patients we worry a little bit more about, just because of a little bit of increased incidence in them and an increased risk, even if they're not hospitalized. We encourage, like I said, those patients to all be very active out running. I think we're all aware, there's a lot of individual athletes, our patients that, do a lot of recreational running. Myself, I'm one of them, and we worry about if they've had that recovered infection and they start to develop symptoms with that physical activity, just that they could be at increased risk for further things coming, and just recommend that they get that promptly evaluated and taken care of. So, kind of an extended answer to that question. We have, as that age goes up and you see their risk for complications be a little bit higher, we do want to pay a little bit closer attention to those individuals.